Good morning, everybody. I'd like to bring another episode of hand surgery lectures for you guys. Dr. Pientka here again. And today I'd like to talk about one of the bigger topics in hand surgery for a while, and that's flexor tendon injuries. And flexor tendon injuries have been well researched and well discussed with a variety of findings and recommendations that can be very confusing. So I'd like to help hash out some of those for you today. We'll also talk a little bit about types of repairs, including the one that I am most fond of here towards the end. So your flexors all start from muscles that arise within the proximal third of the forearm, and most of these are arising from the medial epicondyle and inserting distally either on the hand or in the digits themselves. These transition mostly to tendinous portions in the distal third of the forearm. And this is very important anatomy to know, especially when you're doing, for example, like a spaghetti wrist or something like that in the distal forearm, where you need to know your orientation. And these orientations between the tendons are really maintained all the way from those musculotendinous junctions out to Camper's chiasm, which is where the FDS splits and the FDP runs through it. The FDS tendons will start with flexor digitorum superficialis, and this is a muscle that originates from the medial epicondyle and the proximal radius just distal to the supinator. And it'll split into four parts, two superficial and two deep. And the way to remember which of these are superficial and deep is to sort of put your index and small fingers on the back side of your middle and ring fingers. So your long or middle finger and your ring fingers are the superficial FDS tendons towards the wrists at the carpal tunnel, and the index and small fingers are more deep. These are maintained alignment through the carpal tunnel and can be, again, very important when you're reattaching a multiply injured flexor tendon patient. These tendons do flatten distally and separate into both radial and ulnar bands and create the Camper's chiasm. And these bands actually pass around the FDP tendon and meet dorsally with crossing fibers at Camper's chiasm at the level of the proximal phalanx. And these insert on the palmar surface of the middle phalanx and function to flex the PIP joint. The small finger doesn't reliably have an FDS or a functioning FDS in all patients. This is a picture of my hand here, and you can see that my right hand does not have a functioning FDS tendon. My left hand does, however. And you guys can test this on yourself right now, just as you can see in the picture there. Hold the remaining PIP joints in extension and try and flex your small finger. Now, what we've seen intraoperatively with these patients, that even in patients that don't have a functioning FDS, sometimes you open them up thinking there's maybe an FDS laceration and find that there's just a very diminutive tendon. The other thing that this tells you is, in patients that don't have an FDS tendon to their small finger, they have normal hand function. I have normal hand function in my right hand, full flexion of the small finger, and stronger grip on my right side than my left side, despite not having a functioning FDS tendon here. So what this means is often you don't need to repair both the FDS and FDP tendons in the small finger. FDP alone is strong enough and has enough excursion to allow full motion and full strength. So that has implications when you go to fixing these tendons. Moving on to FDP. FDP is a muscle that arises from the proximal ulna and the interosseous membrane proximally and splits into two main muscle bellies in the mid forearm. The lateral segment of this muscle belly goes to the index finger, while that more medial or ulnar segment goes to the ring, long, and small fingers. And these insert just palmar on the distal phalanx, just at the base of the distal phalanx, and serve to flex the DIP joint as their primary function, although they do provide PIP and MCP flexion as well. Remember, the innervation of your FDP tendon or your FDP muscle is a little bit different, as your ulnar flexors are innervated by your ulnar nerve, but the index and middle finger FDPs are innervated by your median nerve still. The FPL has origins at the medial epicondyle, especially its superficial head. Its deep head, which is the principal muscle mass, comes from the radius and interosseous membrane. And this penetrates through the thenar muscle group and inserts on the distal phalanx to produce thumb IP joint flexion. And you'll see this penetration through the thenar groups if we ever have an FPL tendon that we're rupturing. Sometimes we have to trace that tendon through the muscle back into the carpal tunnel to find it, as it tends to retract all the way back into the wrist. Importantly, with the flexor tendons, and what makes them a lot more difficult to treat, but also a lot more interesting than extensor tendons, is the sheath system. And the sheath system is a synovial membrane that encloses the tendons into what we call a fibroosseous tunnel. The thumb has a sheath that extends all the way down proximal to the wrist crease as the radial bursa. And sometimes you can actually get through that mid-palmar bursa a horseshoe abscess, where an FTS of the small finger or thumb can actually horseshoe all the way across to either the small finger or thumb on the other side of the hand. These sheaths terminate just proximal to the A1 pulley in the index, middle, and ring fingers, but again, the small finger and thumb extend all the way proximally and have a potential space communication between the thumb and the small finger. Blood supply to the tendons is through perfusion, and there's longitudinal segmental vessels that arise from the peritoneum, and this diffusion occurs through those synovial sheaths, or the tendon sheaths. Perfusion is the most significant contribution outside of the flexor tendon sheaths. Okay, so diffusion is where you get more important blood flow outside the sheaths, but it's diffusion within the digital sheaths. And then in addition to that, on the deep surface of the flexor tendons, you have a vincula system, which supplies blood directly to the tendons within the tendon sheath. Also to note here, this is a reason why when you guys have zone 2 or zone 1, even sometimes zone 3, but really it's the 1 and 2 flexor tendon lacerations, that I want you guys to splint them, even if there's not a fracture, because those vincula, while they're very small, can tether the cut end, the proximal stump of the tendon, and prevent retraction, making a repair much easier. But if they're not splinted, any painful or forceful grasping that the patient does can release that vincula and retract that tendon all the way up into sometimes even to the forearm, but definitely into the palm. So you can prevent that by splinting these patients and not allowing them to grasp prior to surgery once they're identified in the ER. So again, outside of the flexor tendon sheaths, blood perfusion, so direct blood flow with those segmental vessels along the peritoneum, is the most common or most significant contributor to tendon blood flow. But within the tendon sheath, it's diffusion of nutrients through the flexor tendon sheath. Knowing where your pulleys are is very important. So your annular pulleys are A1 through A5, and these are the main contributors to holding the tendon down to the bone and preventing bowstringing. The odd-numbered or annular pulleys are over joints. So the A1 pulley is over the metacarpal phalangeal joint. The A3 pulley is over the PIP joint. And the A5 pulley is distally over the DIP joint. It says here A2 and A4 must be maintained, although there is some literature that's come out in the last year or two that shows you really don't need A4 at all, because the middle phalanx is so short that you can't functionally bowstring off of the amount of leverage you get without having an A4 pulley, and you can release up to half of A2. Now, Jimbo Tang out of China has a paper that's in our S drive as one of the critical papers for you guys to read on the hand service, that talks about it's not so much which pulleys you release, but it's the total length of pulley excision you do that has a lot more to do with final outcomes in bowstringing and flexor tendons. So this is not the Jim Boateng article that I'm talking about. This is another one where he talks about being able to release the A4 pulley completely to facilitate a good, solid repair of a zone 2 flexor tendon. And they did not see any significant downside of doing this by releasing the entire A4 pulley. This is a good article for you guys to review. In the thumb, the pulleys are a little bit different. You have your A1 pulley over the MCP joint. You have your A2 pulley distally over the proximal phalanx, and then your oblique pulley between them. And the oblique pulley is the most important pulley to prevent bowstringing in the thumb. You need to be very careful not to go too distal when doing a thumb trigger finger release and getting into the oblique pulley. We break down the flexor tendons into zones in the palm, and this has a direct correlation with type and ease of repair. So zone 1 is distal to the FDS insertion, and this is where there's just one tendon within the flexor tendon sheath, just the FDP tendon. And these are repairs that don't have the same amount of bulk within the sheath, so they don't get the same scarring and difficulty regaining their motion and strength as zone 2. And these are ones that definitely should be repaired. This is like your jersey fingers, for example, the distal FDP avulsions. Zone 2 is basically from the beginning of the flexor tendon sheath, or the A1 pulley, through the FDS insertion. And this is the part of the tendons, the flexor tendons that are within a sheath with two tendons. So you have the most tightly packed tendons within zone 2. This is why this is historically known as no man's land, because any sort of bulky repair here would cause triggering, you'd get scarring, and patients would lose motion. But with new early active motion therapy protocols after flexor tendon repair, we've seen much improved results in zone 2 flexor tendon outcomes. Zone 3 is from the A1 pulley distally to the distal edge of the transverse carpal ligament. This is a difficult repair to do, not technically where you don't worry about the bulk and all that, but you do have the distal branches of the median nerve as well as the palmar arch in the way. So this dissection here has to be extremely meticulous. Zone 4 is within the carpal tunnel, and zone 5 is proximal to the proximal edge of the transverse carpal ligament. In the thumb, the zones are slightly different. So you have zone T1, T2, and T3. T1 is at the insertion of FPL. Zone 2 is from the neck of the proximal phalanx to the metacarpal neck, where you've got the flexor tendon sheath and the oblique pulley there. Zone 3 is deep to the thenar muscles, and then zone 4 and 5 are the same as with the other digits. Flexor tendon healing, this is important to know for testing purposes. There's an intrinsic mechanism, which is where the tenocytes themselves will heal from the cut tendon ends. And then there's an extrinsic mechanism where you get inflammation and fibroblastic invasion. And this is a process that leads to the ultimate strength of your tendon repairs. It's really a combination of both intrinsic and extrinsic mechanisms that allow for tendon recovery, and there really are multiple growth factors that have been identified and involved in tendon healing. The stages of tendon healing: the first 5 days are the inflammatory stage, where you have no strength, no intrinsic strength of your tendon repair, as you're just starting to get cellular proliferation at that point. This is why I tend to immobilize these patients for at least 5 days before getting to therapy, because there is no intrinsic strength of their repair site. That fibroblastic stage, though, which runs from 5 to 28 days, is where you have continually increasing strength and disorganized collagen. So this is where you need to start getting these patients to move, because that fibroblast maturation and proliferation and that disorganized collagen will lead to significant scarring and tethering of the tendons. So we need to make sure our tendon repairs are strong enough to withstand early motion during this fibroblastic phase to prevent uh, scarring the tendons down to the sheath. And then after 28 days, you get a more linear organization of the collagen. This is the remodeling phase, and this is traditionally when patients would be allowed to do controlled active motion, although with new repair techniques, we're doing immediate active motion after that once we start therapy in that fibroblastic phase. So, tendon injuries, these patients will have a loss of active flexion of the involved digits. A wound may or not be present. They may be an avulsion. If you have a rock climber, if you have a jersey finger, a lot of athletes will develop these. Um, we've seen several where patients have like fallen from a ladder or roof or something and grabbed on to try and catch their fall and ruptured a flexor tendon, the FTP. If you look, you want to examine the digit for any sort of malrotation to raise your concern for a fracture. You also want to look at the cascade of the fingers. So have the patient just rest their hand down dorsally. And if, all their fingers are in a slight resting flexion, which is the normal cascade, except for the digit in question is fully extended, that, would make you think that there's a high likelihood of flexor tendon injury. And then the loss of the tenodesis effect. So take the wrist into full extension, the fingers should come into passive flexion. And then as you passively flex the wrist, the digits should just extend. Now, if this is not intact, you need to have a high suspicion for tendon injury. Observation, again, is very important. The squeeze test it can be helpful as long as there's a complete laceration. If you've got even a 90% high grade flexor tendon laceration, you squeeze over the muscle bellies or the musculotendinous junctions in the forearm, you'll still get a little bit of flexion in the digit, and that can be very misleading. Tenodesis effect we just talked about, and then active motion, of course. And when you're testing these patients, you need to test each tendon individually. So you have to check FDS and FDP to each finger as well as FPL. And the way that you do this is by stabilizing and counteracting the force of the opposite tendon. So, for example, in the index finger, if I want to test FDP, you have to hold the PIP joint in extension and tell the patient to flex their DIP joint. And then to test the FDS, you have to hold all the remaining digits in full extension and have them flex the index finger. And if you hold the distal phalanx and the DIP joint in extension of the other fingers, you'll get isolation of FDS in that finger. And you can do this for each finger by holding the remaining fingers in full extension. This should also be documented that you tested FDS and FDP to each digit when you're examining these patients. If patients have weakness or pain when doing this, that can be a sign of a partial tendon laceration. You should have a high suspicion for this. And it's often a lot of partial tendon lacerations or even complete tendon lacerations can be masked by a patient who's unwilling to move their finger because of a fracture. But really, that's your impression. But in reality, they're unable to move the finger because of a tendon injury. So again, if you need to do a digital block or whatever to counteract that pain to allow you to get a good exam, it's critical on every hand injury that you see. There are some contraindications to treatment of flexor tendon injuries. Active infection, of course, is one. We generally use braided sutures for the repair of these, so you wouldn't want to use that in the case of an active infection. If you have a really dirty wound that you can't get clean enough at the initial debridement, you might hold off for a couple days on doing your tendon repairs. If the soft tissues are compromised, you don't want to leave your repair site exposed, so you might need to consider some sort of coverage either at the same time of a repair or prior to. And then in certain patients, they'll have systemic conditions like scleroderma being one, where they just don't have the capability to really heal. So those would be relative contraindications to doing flexor tendon repairs. Non-operative treatment. So if you have a partial laceration, which you've visualized to be less than 60% of the tendon cross-sectional area, you can treat these non-surgically, although they can lead to triggering and reduced flexion just due to a gap formation that occurs. So you have decreased lever arm to provide that full flexion. If noted intraoperatively, sometimes you want to trim back part of the laceration itself to decrease bulk, to decrease the likelihood of triggering. But most of these are going to be treated operatively. And operative treatment is really indicated for any tendon laceration greater than 60% of the tendon width or that cross-sectional area. A lot of these are going to be fixed within the first week, and it's best done within 21 days. If you get more than 21 days, not only do you have sort of breakdown of the collagen at the tendon ends, but you get so much muscle stiffness and shortening proximally that can be really hard to get your excursion back to get a primary repair. And the outcomes are directly related to the zone in which the repair is performed. So zone 2s do worse than zone 1s and zone 3s for sure. Zone 5s have the best outcomes because you just don't have the space limitations and the density of nearby structures to scar to and prevent good outcomes. But with these, and what you guys will hear me tell all our patients is that the perfect flexor tendon surgery is a waste of time without appropriate therapy. And if these patients are unwilling or unable to go to therapy, you need to counsel them that you can make them worse by doing surgery on them. You can make adjacent joints stiff. They can get infections. But if nothing else, you're giving them a large bill with no benefit if they're not going to go to the therapy to make sure that your tendon repair is successful. The approach for flexor tendon repair is done with this Brunner incision, and the rationale for the Brunner incision is to avoid crossing flexion creases at a 90-degree angle or perpendicular to those flexion creases, because those scars will contract and you'll end up with flexion contractures. So we do Brunner incisions, which bypass the flexion creases here so that the scarring is off axis to the line of pull of the scar that will eventually develop. You want to do these as soon as possible, generally within 7 to 10 days. Sheath repair is controversial. There's some people that talk about doing tendon sheath repairs. Generally, I do not, because that is just an additional source of scarring for these patients that already have difficulty regaining their motion due to scar. You generally want to preserve the A2 and A4 pulleys if you can, although we did talk about being able to fully release A4 with no problems, and I have very little hesitation to do this. And you also want to retain the oblique pulley in the thumb if at all possible. There's a linear relationship that's been developed or established between the number of core sutures crossing the fracture site or the repair site and the strength of that repair. And what all the literature says is you really need a minimum of 4 core sutures crossing your repair site to have enough strength for an early active motion. More sutures is better, but once you get to 8 or more, you have so much bulk at the repair site that you end up getting an increased coefficient of friction between the tendon and the sheath, which actually decreases your ability to regain motion. So what the general consensus in the hand community is that 6 strands is sort of the sweet spot. A high-strength suture should be used for this. I like the super mid suture. I use a 4-0 super mid suture, which is a looped braided suture. And I use the limb psi repair, which you can see here, a demonstration of this on an FDP tendon. And with the limb psi repair, what you see is not only is this going to be a 6-strand repair, so each pass across the repair site is 2 strands because it's a looped suture. So you have 6 strands there, but you also see that my assistant here is holding a 6-0 Proline that we've used and placed our epitendinous suture on the deep surface of the tendon and holding those tendons, just kissing. Just what I tell you guys in the OR, it's like kissing your grandma. You want to have enough contact to get credit, but you don't want to feel like you made more contact than you needed to. And that's what your assistant does here. So they're just holding that suture. If you pull a 6-0 Proline too hard, it'll break, but you're just holding it there. And then the limb psi 6-strand repair is a locking repair. And this provides you with an excellent repair that is bulk free and doesn't allow for gapping. So another article here talking about zone 2 flexor tendons and current trends. And this is where you see on the bottom here, the majority of surgeons are saying that a 4-strand repair is adequate with either a 3-0 or 4-0 braided suture. And in addition to an epitendinous repair, not many people in the U.S. doing wide awake flexor tendon surgery, although there are some, and there's some benefits of doing that you can have the patient actually flex after the repair to make sure that they're not gapping or triggering at the tendon site. Again, that circumferential epitendinous suture is extremely important. And what you saw in that image a few slides back, we had just done the backside. Then we do our core suture repair with the 4-0 supermid. And then we continue that epitendinous suture over the front side and repair it back to itself, providing a circumferential suture. And not only does this improve tendon gliding by decreasing the bulk of the repair site, but it also adds about 20% to the tensile strength of your repair and prevents early gap formation, which is really the first step that allows for tendon repair failure. Here's what the limb side technique looks like. So on the bottom left and the top right, you see where you've placed the looped suture through a portion of the tendon and locked it to itself. And then you pass that tendon parallel along the course of the tendon across the repair site, coming out equidistant, so at the same spot where your other suture is on the other side of the repair site, passing the needle back through the loop to lock it there. And then each suture is passed through in an oblique fashion the center portion of the tendon, and at point 2 is where the knot is tied inside the tendon itself. And once that knot is tied at point 2, then the epitendinous suture is repaired over the superficial surface of the tendon. So Don Lalonde in Canada is sort of the godfather of wide awake hand surgery, and he talks about doing these without tourniquet or sedation, using Lido with epi, and that this allows for intraoperative assessment of both repair gap as well as guiding, and to make sure that there are no triggering. And by doing this, you can confirm that your repair is strong enough to get that patient into an early active program. This isn't something that we've done here yet in Fort Worth, but it's certainly something that I'd be open to considering. As far as rehab, the single most important reason that zone 2 flexor tendon reports of success have improved over the last several years has been in the post-op rehab. And what you are seeing is not only improved tendon healing with superior strength, but more motion and earlier return to motion, because you're limiting the restrictive adhesions that form by having those tendons not moving. By being able to get those tendons, that tendon excursion back early, you're restricting the formation of adhesions between the tendon and the tendon sheath. In non-compliant patients and kids, though, you have to immobilize these, because a tendon repair that fails due to non-compliance or being unable to follow restrictions is way worse than trying to work out a stiff finger. There are the Kleinert and Duran are sort of low force, low excursion, early passive motion protocols. The place and hold, for example. The Mayo Clinic developed the synergistic splint that allows for active wrist motion, which is low force, high excursion. And what we're doing in Fort Worth here is an early active motion protocol. So at 5 days, we start getting the patient into a thermoplast splint. They're starting passive range of motion and active motion into a half fist. So 50% fist to allow for high excursion and low to moderate force, because we're doing a 6-strand repair with an epitendinous suture, and we've not had a single failure in somebody who's been compliant with these restrictions. There's definitely complications after flexor tendon injuries, and they can be from failure of repair, they can be stiffness, The most common complication you're going to see is adhesion formation, and this can be permanent, even with a tenolysis. In the future, sometimes you just can't get these patients' motions back. But other patients we've seen develop PIP flexion contractures, triggering, bowstringing, even quadriga or swan neck deformities, lumbrical plus deformities are things that can happen as well. Now, you can prevent this with a very, very meticulous surgical technique and then a strong post-operative, well-supervised therapy program. And that's what we're trying to develop here at JPS. So again, complications we talked about, most common is tendon adhesion, re-rupture, joint contracture, and then some of these other less common complications as well. The repair is functionally the weakest between 6 and 12 days. I mean, really, it's 0 to 5 days is when you have no intrinsic strength, but your healing repair is weakest when you start letting them move on day 6. And the repair usually fails at the knot level. So you need to make sure that your knots are square and solid here. You can't have any sloppy knot tying when you're doing flexor tendon repairs. It is important to identify failures early so that you can perform a prompt revision. And sometimes passive motion rehab protocols can conceal failures because you're not actually having the patient activate the tendon, so you can't identify that they're unable to do so. Quadriga is a problem you guys should know about. This is from a functional shortening of FTP or over advancement if you have to trim back frayed tendon ends. And with, as you can see here in the image, what you got was over advancement of the FTP to the middle finger here. And now with full excursion of that middle finger, the patients can't pull down their FTPs of the index and ring fingers. And it's because that there's a common muscle belly between these 3 fingers. A lumbrical plus finger, just so you guys are familiar with what this is a paradoxical extension of the PIP when the patient tries to flex their finger. It's most common in the middle finger, and it's due to a transected FTP that retracts with flexion and pulls through the lumbricals. And those lumbricals extend the IP joint. So you can see this in patients who've had a DIP level amputation or an FTP avulsion, or if you do a tendon graft on a staged tendon, 2-stage tendon repair, and you have excess length of the tendon repair, this is a problem that you can see. And this is what that'll look like. So you can see this patient's had a FDP or a DIP level amputation. And now when they try to make a fist, they're actually getting an extension force through their IP joint from their lumbricals. In these patients that develop adhesions, you can consider tenolysis in the future, and this is indicated for tendon repairs when they have no ability to actively pull down through the tendon sheath, but they have full passive motion without contractures. And there's typically, in patients who would benefit from a tenolysis, a large difference between active and passive motion. So passively, you can get them into a full fist, and actively, they lack that motion. These are patients that would do well from a tenolysis. Now, if you can't passively get someone into a full fist, they're not going to benefit from a tenolysis because they're only going to be able to actively flex to the position that they can get to passively. They're not going to be able to overcome those joint contractures. Normally, you want to wait until tendon is completely healed and the soft tissues have stabilized for this. I tend to tell patients it's best to wait about 6 months. And then after you do a tenolysis, they need to go to therapy as much as they can to prevent any new adhesions from forming. One of the last things we'll talk about here is stage tendon reconstruction. So this is the flexor tendon that you can't get to right away. It shows up late or whatever reason. The tendon sheath of the tendons themselves are in such poor shape you can't expect normal tendon gliding after a primary repair. Stage tendon reconstruction needs a sensate digit. It needs a digit with good vascularity. It needs access to therapy. And it's best to wait until your soft tissues have reached an equilibrium to perform this. And what's done with a stage tendon reconstruction is the first stage, you excise all the damaged tendon. You address or reconstruct pulleys as needed. You can use tendon that you excise, for example, the FDS tendon, to reconstruct the A2 pulley if needed. And then you use a silicone sheath, which is a hunter's rod, which is made by Wright Medical, is the one that we use. And this is basically a tendon surrogate that's placed to allow for a tendon bed, a pseudo sheath around this silicone implant to form. And that typically takes 3 to 4 months. And during this time, the patient is still going to therapy to maintain their passive flexion of the digit. And then after that latent time period, once your tendon bed is created, you go back in for your second stage as long as the patient has full passive range of motion in the digit. And you can use palmaris, plantaris, or toe extensors to graft from the distal aspect of the finger. So you're only, when you're doing two-stage reconstructions, you're only reconstructing the FDP. So you'll tie either to remnant FDP or suture anchor into the distal phalanx, run your tendon graft, you're pulling it through your pseudo sheath, and then attach it to the proximal tendon stump. And it's really important to tension these correctly so you don't create either a quadriga effect or a flexor lag. I hope this clears up a lot of questions you may have had on flexor tendons. When you're on the hand surface, we'll certainly get lots of opportunities to fix these, even with the current restrictions, as these are emergent conditions. We are still performing these as they come in. As always, please let me know if you have any questions or concerns. If you need any more reading material or want recommendations on what else to look at, please let me know. I hope you're all doing well and hope to see you all back in the office and back with our normal activities soon. Thank you.